the work that we're going to be doing for Medicaid transformation in our area, and then an overview or a construct of the collaborative itself. And it's really our goal or our intention that the collaboratives and the Spokane collaboratives, so all of you smart folks, have a self-governing, self-run collaborative as you work through these project plans. But then we thought, well, we can't really ask these folks to do that when they've never probably convened before. So today, and then April 10th and April 26th, we're going to be laying the foundation for all of you to do great work going forward. So hopefully that makes a little bit more sense, because I think there was still some questions around what is it exactly that we're doing. So hopefully that helps there. Today, or this afternoon, we're going to be doing some partner introductions. So a little bit about getting to know each other and what each other does. There's still some folks who will make comments saying, well, I would love to partner with other organizations and entities, but I don't know who does what. I don't know what that organization does, or I don't know if there's an organization that does X, Y, and Z. So that's going to be part of our work today, part of your work, to be frankly honest. Then we're going to be just doing a very brief overview of the Medicaid transformation work, hopefully why we are all here. And then we're going to be taking a dive into what is the role and expectation of not only the collaborative, so this group of folks, but also each and every one of your organizations within that collaborative or under that collaborative. Then we'll have some time for some question and answer, because I suspect, I'm just going to go off the hunch here, there might be a couple questions about what is this. So we'll have some time set aside for that. And then in the after a break, we'll do some discussion. So that's our outline for today. And let's go ahead and dive in. And every time I use this, it never quite works the way I want it. Okay. We're off to a good start. So some of you might remember this slide when we were doing the 101 presentations, and we were talking about, we really wanted the collaboratives to have these different settings that are in some way or aspect involved with Medicaid and with the system of care. And so the entities that you see listed up here are organizations that have either submitted their memorandum of agreement and or have indicated that they will be. So these are the partners in the room, just to give a visual. And so with that, I'm going to ask that we start, and this is going to be quite a process, I understand, so I appreciate all your patience. But we really need to get to know each other and what each other does. So as we go around and do introductions, please keep in mind that there's going to be a lot of people in this room who do not know what your organization does. And so it's key not only to introduce yourself and what you do, but then hit the highlights about what your organization does, specifically around serving Medicaid individuals. Okay? So I'm just going to go at random, and I'm going to pick Mr. Ron Simpson in the back, because he's called me a few times this week, so that's how you get picked. And Ron, if you don't mind just starting introductions, and there's a microphone, should be a mic in the middle of each table, and Devin here will also help if you don't have a mic, but Ron, kick us off.
Okay, so you want to know what we do?
Yes, sir.
Okay, well, I'm Ron Simpson. I'm the administrator over at Sunshine Terrace, which includes the Sunshine Residential Treatment Facility as well as Sunshine Behavioral Health. And we have we have 3 residential settings there at the Terrace, not completely campus-wide, but in terms of what we're doing. And we oversee primarily mental health clients, case managing, and also in the treatment center, we oversee and do residential treatment there. As far as the Medicaid, most of the clients that we have come through that we case manage, that we service, most of them are Medicaid clients. We do have a memory care as well, but obviously that's outside the scope of what we're talking about today here. So that's pretty much what we do.
Appreciate it. Okay.
Hi, my name is Kate Rowe, and I'm with the Institute for Family Development. And my role as the mental health coordinator at our agency in Spokane, and I'm also the supervisor of a WISE team, which is wraparound with intensive services. So at our agency in Spokane, we have a WISE team and also a home builders program, which it's both hospital diversion in home intensive counseling.
Thank you.
Thank you.
I'm Amy Hood. I am a mental health professional at the Spokane County Jail and the Detention Services. We provide medical, mental health, and substance abuse screening and treatment to any adults who come through our jail. As far as Medicaid goes, they may be Medicaid eligible if we're not providing Medicaid reimbursable services because of where they are. But we do ensure that everyone is applied for and their Medicaid is reactive before they leave the jail. And we do a lot of discharge planning to make sure they have access to the services they need once they leave us.
I thought I could sit in the back and get away with not saying anything, but I'm Kai Neville. I work for Yakima Valley Farmworkers Clinic and oversee operations for our 3 sites here in Spokane. Our bulk of our business is dealing with Medicaid patients. We have primary care primarily, and then dental, pharmacy, behavioral health, dietary, those types of services. I'm really excited to see a lot of people here. I know there's been a lot of work being put into this on the BHT side as I sit on the board as well. So I'd like to say welcome and thank you all for attending today.
Hello, everyone. I'm Allison Polson. I have a new last name. Yeah, I'm also a Leo, so like a lot of attention. I just want to take this opportunity to say thank you. When we started conceiving of how these dollars were going to flow into the community, we kept envisioning this circle diagram and all of you in the same location actually figuring out how do we radically improve health in our community, and to see it come to fruition today is just amazing. I'm not sure what my job is, but I'm here.
Hello, my name is Andrew Bingham. I'm the new Children's Mental Health Project Coordinator with ESD 101. That's the Educational Service District 101 here in Spokane. We serve 59 school districts throughout our area across 7 counties and about 100,000 students in our area. About half of those are Medicaid eligible. So the purpose of my position in my program is for the next year and a half, we're going to be reevaluating the services, the mental and behavioral health services that our students receive in their respective districts and schools. So part of that's going to be meeting with all you wonderful people, figuring out where you fit kind of in that big picture of services throughout our communities. And a week ago, I had no idea how I was going to reach this many people in different positions. So in one fortuitous moment and meeting with Charisse, this became possible. So thank you for being here, and I'm looking forward to meeting all of you individually.
Hi, I'm Reese Holford. I work in the Transforming Clinical Practice Initiative here in the Better Health Together region. And right now our focus is integrating those specialty care clinics with primary care clinics. So I'm really, really excited to be here. My focus is on pediatric Medicaid patients. So if you see those patients, come see me. I would love to talk about it.
Hello, I'm Tiffany Kelly with Lutheran Community Services. So we've got a couple of different programs across our agency. We have a victim advocacy that kind of falls outside of the scope of behavioral health and those Medicaid dollars, but we definitely have a lot of those same clients that are accessing both our behavioral health systems and that advocacy team. So just to know that that's a part of what we do and in the community. And then we also have an outpatient mental health team that's pretty traditional, specialized in trauma work and youth-based work, but also see people kind of across the age continuum and continuum of needs. And then in our child welfare team, we have some clinical outpatient work that specializes in sexualized behavior problems. And then we have 2 WISE teams, and then we also have the FOCUS program, which is hospital diversion, kind of with the home builders. They're on that same scope. Yep.
Hi, I'm Kathy Pham, Director of Community Minded Enterprises. And first of all, we have a long-standing program where we provide childcare for anybody who is low income in an outpatient treatment program so they can complete treatment easily. We also have the Recovery Cafe, which is right down the block. If you ever want to drop in, it offers peer recovery services and outreach. And then, looking at my list here, we also offer the Community Living Connections line, which is for seniors, but we serve a lot of Medicaid who are seniors prior to beginning on their Medicare. And we are long-standing health navigators.
Hello, I'm Lynn Kimball, the Executive Director for Aging and Long-Term Care of Eastern Washington. We're the local area agency on aging. When it comes to Medicaid, we oversee the case management and help provide the case management system for Medicaid adults who receive long-term care in their homes. So they have a caregiver or someone who's coming in to support them to stay stable and at home. We're also responsible for implementing Initiative 2 of the waiver here in our region, which is helping to support unpaid caregivers and continuing to provide care. And those individuals who are either currently eligible for Medicaid or who have not yet spent down to Medicaid. We also provide care coordination through the Health Homes program. And I'm also a Better Health Together board member, and I'm excited to see so many new faces I haven't met today.
Hi, I'm Amber Johnson. I'm the Director of Mission Support at Spokane Neighborhood Action Partners. We're Spokane County's community action agency, and we provide housing, homeless services, financial stability services, and also are growing a ER diversion program, which is transportation alternative from the ER to urgent care in conjunction with our friends at Spokane Fire Department and Spokane Valley as well. So we are involved in a variety of program areas, about 30 program areas, and we served close to 49,000 people last year. So.
I'm Mike Lopez. I'm the Integrated Health Services Manager for the City of Spokane Fire Department. And the Fire Department, in addition to providing acute care to people who are suffering sudden cardiac arrest, strokes, cardiac arrest, or heart attacks, those kinds of things. We also have several innovative programs that really are founded on collaboration and integration into the health care system. Amber mentioned the Right to Care program, where we're actually now identifying people with low acuity conditions and actually getting them to an urgent care as opposed to tying up the emergency departments in the city. We have our CARES team, which is a social response group that is really, it's led by a master's in social work, licensed social worker, and is a source of practicum for social work students, where we get referrals from the firefighters to go and check on and link people with resources in the community. We've got the hotspotters that we're actively involved in, and yeah. So thank you.
What he said, essentially. My name is Brian. I'm the fire chief. I work for him, and I'm a fan of hers. And I'm just going to pass the mic. So who's next? And I'm a fan of hers too, very much so.
Hi, my name is Emily Fleury, and I'm the Director for Community Wellness at Inland Northwest Health Services. And we mainly do chronic disease prevention, diabetes prevention, and treatment. So that's how we play a part here.
My name is Cindy Green, and I work for the Spokane Regional Health District, and I manage the Healthy Communities program. And what that is primarily a chronic disease prevention program focusing on creating a healthier community through active living, healthy eating, tobacco, vaping, and marijuana prevention. We also work on senior falls prevention. And the health district does much more than that, and I'm happy to see 20 here as well, because he knows more about everything else.
My name is Brandy from Spark. I'm the office manager. We have multiple levels of care, SUD treatment, co-occurring mental health, and then we also have partnerships with Providence Sacred Heart, the CSO offices, and Sunshine Terrace.
I'm from Spark, Linda Kruger Spark.
I don't do much of anything, really.
That's a lie, is what I'm just calling you.
Well, good afternoon. My name is Carl Eastland, and I'm here on behalf of Planned Parenthood. I'm the local CEO. As many of you know, Planned Parenthood does everything related to reproductive health care in this region for a large group of Medicaid patients. We also are starting to do more and more primary care, as many of our patients are finding it difficult to have access to standard basic primary care at other providers in town. In addition to that, we have a pretty advanced education program. We partner with local school districts, also faith-based groups or just private groups that want access to medically accurate sex education, which we really believe in. And lastly, I just want to mention some of our advocacy work. Our board is very dedicated to the concept of health equity for all, so we are always looking at ways that we can advocate for populations that are underserved in our healthcare system.
Hi, I'm Joy Peltier. I'm the Chief Strategy Officer at Planned Parenthood with Carl.
Hi, Mike Weiser with Chaz Health. I oversee strategic planning and project management, and we're a federally qualified health center with about 9 clinics in the Spokane area. We have a couple urgent cares. We do primary medical care, integrated behavioral health, pharmacy, dental, and have some nutritionists and all that sort of stuff. You're next.
Hi, Nicole Thomas, Sunray Court, New Horizon Care Centers, specifically at the Sunray Court facility. We do primarily substance use, inpatient and outpatient. We've got Sunray Court that does the inpatient male only. When we have Isabella House does the pregnant parenting with children inpatient, and then 2 outpatient centers for substance use and co-occurring mental health, both in downtown and the Valley.
Hi, my name is Tom Cook, and I'm the administrator of Sunray Court, which you just described. So we do residential treatment with men. We get referrals from all over the state, and we have long-term residential, we have recovery house, and we have intensive inpatient.
Hi, good afternoon. My name is Kathy Olson, and I'm with Molina Healthcare. We're one of the 5 MCOs that are currently in this area. We serve about 85,000 Medicaid lives here just in Spokane. And in addition to paying claims currently for physical health services, we have very active teams in the community who provide community events to help support fundraising for different activities. And we have a very strong case management team here in the community who links with many of your organizations to help people get linked to the services they need to improve their lives. Thanks.
Hi, I'm Dr. Monica Blakowski-May, and I'm a family practice physician and administrator with Rockwood Clinic. And many of you known about us. We've been here for a long time. And we are recently affiliated with Multicare. So Chris Werity is here with me today, also associated with us. And we obviously serve patients in our community, many of which are Medicaid.
Sure, I'll skip.
Hi, I'm Lilia, and I'm AmeriCorps Vista and also community health worker, and I am here to build capacity to provide oral health access to people and provide prevention education in schools for mostly Medicaid patients.
That's hard to follow because she's my Vista. My name is Paula Williams. I'm from Operation Healthy Family, and I am here to provide access to care for Medicaid patients and oral health and dental needs, as well as in schools and communities to teach people that your mouth is connected to your body. So thank you.
I'm Nicole Manus, and I'm the Community Health Director for the YMCA, and I primarily oversee the programs that interface with the medical community.
Hi, I'm Kim Longhopper. I'm with Spokane County Supportive Living Program, and we offer services for mental health and co-occurring individuals. It's case management, but we do a lot in housing and community integration.
Hi, I'm Amelia Davis. I'm also from one of the MCOs. I'm from Coordinated Care, and I'm one of the local reps here in the Spokane area.
Hello, Chris Mullen with Riverside Recovery Center. We're a medical behavioral health clinic specializing in substance use disorders. Probably about 85% or so of our clients are Medicaid. We have a medical director and then a couple nurse practitioners providing buprenorphine services, so Suboxone or Subutex. Thank you.
Ryan Kiley, I'm the Chief Clinical Officer at Excelsior, and we have primary care, behavioral health continuum from intensive inpatient to IOP and partial hospitalization and outpatient. We also have an education arm. We have an on-site district-affiliated school and a bunch of smaller programs that work on diverting people from high utilization in the emergency departments. And we have a couple different grant options that allow us to use funding in a creative way to move the needle on social determinants of health. So we screen for those and try to provide concrete resources for those individuals to divert from high cost utilization.
I'm Carol Pliski. I'm the Executive Director at Partners with Families and Children. And we have several different programs within this. I'll let our director share about mental health and substance use disorders. But we also are a nationally accredited children's advocacy center, which includes, we have a medical team that are experts in diagnosing child abuse. So we do exams in our clinic, which can help divert from having to go to the emergency room. And we also have a medical team that will go to the Children's Hospital, or I'd love to connect with Multicare as well, because they can come there as well and provide child abuse diagnosis exams.
Hi, I'm Kathy Dorn from YFA Connections. We've been working in Spokane since 1969, and we do outpatient substance abuse disorder treatment for Medicaid adults. We also do co-occurring mental health and substance use disorder treatment. We have mental health therapists stationed in 13 schools in Riverside, Deer Park, and 9 Mile school districts. And we also run the Regional Crisis Residential Center, which is for homeless and at-risk youth ages 12 to 17. Thanks.
Good afternoon, Danielle Cannon, also with Excelsior Youth Center. I'm the Director of Strategic Initiatives and Partnerships.
I am Pam Brown from Catholic Charities. We have a small mental health program specializing in DBT groups, EMDR, and chronic pain, and then a lot of generalist work. We also have the House of Charity, St. Margaret's Shelter. We have low-income senior and disabled adults housing. We have a program for young moms and dads and their babies. They do a lot of social security work. And we have a program through St. Margaret's Shelter, which is Pathfinders. So that's the opioid, or part of the opioid response. They do the GOSH program, which is getting folks coming out of Eastern State Hospital housed, supportive housing and supported employment services. We also have senior transportation, and we have Food for All, which is a farm where they grow food and work with the other community partners.
So I just have to say, I think I have known some of you for many decades, and I have really no idea what you do after listening to you. I mean, this is really impressive. I'm learning a lot. So I'm just gonna move the mic here.
Maureen Rosette from the Native Project.
I'm Tony Lodge, and I'm the CEO of the Native Project. I have to write myself notes because I'm of that certain age. We do primary medical care, dental, pharmacy through the Indian Health Services and a HRSA 330 contract, community health, much like Unify and Chaz. We do chronic disease management through the Indian Health Services, diabetes. We have 2 diabetes educators, registered dietitian. We're state licensed mental health and substance abuse. We do Indian child welfare, lots of prevention. We have a CSO officer on site. 60% of our patients are Medicaid. The other 40% likes to come because we're one of the primary culturally specific healthcare centers in this area. And we are an NCQA patient-centered medical home level 2 recognized clinic. Oh, wait. I'm supposed to put this around it because it's flu season.
Tony is always caring about our health. Thank you.
Hi, I'm Kathy Hedgecock. I'm with Second Harvest.
We've been the central hub for charitable food distribution in the region since 1971. And today, that involves partnering with about 250 partner food banks, meal sites, and other programs that are getting food to where it's needed most here in Spokane and throughout the Northwest. That's 21 counties here in Eastern Washington and 5 in North Idaho. And it covers all the counties served by the Better Health Together footprint. That also includes our mobile market, which is really focused on filling service gaps in so many rural counties that are underserved and moving more of the fresh produce that we have access to and other healthy food. We've also lifted up nutrition education and health-related initiatives as really high priorities as strategies for improving food security and self-sufficiency in the region. Just happy to be part of this. Thank you.
You can use the spray too if you don't use the
Good afternoon. My name is Tony Smith. I'm the administrator of Spokane Regional Health District. In terms of what we do with Medicaid, there are direct services such as our maternal child health through Nurse Family Partnership or the Earlier Intervention Program or Children with Special Health Care Needs Program. The largest population that we serve are those in opiate treatment. And that is a direct billable. But I think as Tony pointed out with the Native Project, a lot of the work that they do is preventive, is not necessarily billable, but it impacts Medicaid outcomes. So what you heard Cindy talk about in terms of healthy communities, we don't get reimbursed for doing communicable disease or chronic disease epidemiology, tracking outbreaks, but it clearly impacts communities, in particular those communities who are minorities that struggle with other social determinants seem to have more of the challenges that end up as being disease oriented. So we kind of cross the spectrum, clearly are engaged in the behavioral health arena. We are building the mental health component into our opiate treatment program for improved access at this point. So thank you. And Sharice is coming back to you. Oh, I'm sorry.
Hi, Jenny Slagle, Associate Director here at Better Health Together. I'm leading the community-based care coordination work, and I support our tribal partners here in the region.
So I'm Stephen Miller. I'm the Director of Adult Services at Volunteers of America, and our biggest function is housing for the homeless. So we do have 2 shelters, one for crosswalk youth, 13 through 17, and Hope House Women's Shelters. We also have 172 units of permanent supportive housing, several transitional housing programs, one for veterans, one for youths transitioning 18 to 24 into housing, and then we have the visitation program for families involved with CPS. We also have a foster youth program that helps youth transitioning out of foster care into life on their own. So a number of programs, almost everyone we deal with is Medicaid eligible. So.
Hi, I'm Colleen from Partners with Families and Children. I'm the SUD Clinical Director, and we have an intensive outpatient and outpatient treatment program.
And I'm Christy Pells, also from Partners with Families and Children, along with Colleen and Carol, and I'm the Mental Health Clinical Director. I think the only additional piece to add, obviously we provide mental health services to the Medicaid population, and we have our niche is serving primarily the families that are involved with children's administration, providing those mental health services to children and adults. In addition to touching on the prevention piece, we're wanting to invest more and more there, and primarily right now we're building and have a strong parenting component as well with several EPPs.
So I'm still learning, and I hope all of you are. And I was just saying to Justin as we were hearing folks go around the room that it would be wonderful if we get all of our organizations and we do like a 3 or 4 bullet point. Just saying, because I think I've learned a lot. So we'll kick it off to Mary.
Hi, I'm Mary Beezer with Children's Home Society, and I'm the clinical manager.
Hi, my name is Rick Purcell. I'm the Director of Children's Home Society. We primarily, with the Medicaid population, do outpatient child and family counseling. We have other programs as well, but Medicaid-wise, we only do the child and family outpatient.
Hi, I'm Kelly Miller, Director of Compliance, Clinical Support in our Health Homes program at Frontier Behavioral Health, but I'm going to let him do the list.
Right.
So I'm Jeff Thomas, CEO of Frontier Behavioral Health. I'm also a BHT board member, and I'm thinking back to February of 2011, and some of you recall that, and others of you are newer to the community or to your role since that time. There was a convening that was brought together by Christine Barada and Susie McDaniel on the campus of Gonzaga University. There was a couple hundred people that got together there, and it was to kind of put forth this concept that was emanating from where our state was going, and it was titled regionally a regional health authority. People recall that, a few of you? And there was not a lot of structure to what that would look like, and not a lot of guidance. So a number of us continued to get together for a while, but absent real direction or sense of what would be accomplished through that, it sort of winnowed down to a very small number. And then we thought, and I remember Christine and Susie and I and a handful of others, we thought maybe it's the word authority that's scaring people off. So we changed it to Regional Health Alliance, which was more friendly. But still nobody showed up because there's no structure, no meaning to be there. So eventually the state started to put more form and structure to what might be accomplished through these entities, and Empire Health Foundation was engaged and graciously kind of took on sort of a sponsorship role, and that became, you know, the seed for what was Better Health Together, which is now what you see here. So kind of quite a story as to seeing what's now in play, and it's not quite clear, at least to me, as a BHD board member and as a CEO of a behavioral health organization, exactly what we're going to be accomplishing, but it seems like it's worthwhile for us to all be here. So a little bit about Frontier. We're a largely public funded organization doing mostly behavioral health care services. We provide an array of outpatient services to all ages. We serve about 16,000 people a year. We provide crisis services, so the ITA evaluations by our DMHPs, soon to be renamed DCRs as of April 1st. We provide mobile crisis services. We have 2 16-bed inpatient ENT, evaluation and treatment units, a 16-bed stabilization program. We've got we do 12 WISE teams, provide the medication management services for our public funded mental health system of care here locally. We have one of 2 internationally accredited clubhouses in our state called Evergreen Club. You may have heard of it. What else do we provide? We do health homes services. We've got a dozen staff engaged in that on that team. We provide under ALT-Q funding at our elder services, a variety of different services, that family caregiver support, coach program, a few other things. What else do we have that I'm missing here? Just some of our other partnerships with law enforcement. We pulled together the crisis intervention team, or CIT training, for the last 15 years. It's an important part of our partnerships with others in the community. And we also, have partnerships with new and evolving ones with many different primary health care, physical health care provider organizations. That's probably the highlight reel, so thank you.
Geez, thanks, Jeff. My name is Blake Brady, and I'm the Executive Director for Spokane Treatment and Recovery Services. We offer a wide array of behavioral health services, such as withdrawal management for youth and adults. We offer the Emergency Service Patrol in partnership with the fire department. We offer intensive outpatient that is co-occurring for adults. We offer long-term residential for co-occurring men and women. So basically, we are 100% Medicaid clientele, 100% Medicaid funded with a few contracts on the side. But I'm a firm believer in this innovative project. I'm a firm believer in the integration, and I'm just looking forward to adding to these services and partner with you guys. Thanks.
Hi, I'm Dorothy Poppy. I'm with the American Indian Community Center, Good Heart Behavioral Health. We're brand new, so we do outpatient level, intensive outpatient, 1 and 2, and we do DUIs, and I do billing. Very important.
Good afternoon, everybody. My name is Kat Latte. I'm with Community Health Plan of Washington. We are the only not-for-profit managed care organization in the state of Washington, also Washington-based. And we are the second largest health plan within the state and serve around 23,000 lives at this point in time within the Spokane region. And just really excited to be here. This is pretty magical. So echoing what Jeff was saying, I used to work at the Healthcare Authority and had a part in dreaming up some of this work around accountable communities of health. So when our friend here from the ESD said, what is the opportunity of seeing all these people here? This is the magic that can happen when everybody comes together. So it's just great to be a part of it.
I'm with these guys.
Well, you don't know.
I'm with these guys. I'm Marie Olison, and I'm with Children's Home Society.
Now.
I do.
Good afternoon, I'm Becky Bates, the Executive Director of Passages. We do primarily Medicaid outpatient mental health, therapy, case management, peer support. I think what distinguishes us is that we do 99% of our services in the community. We don't do 50-minute hours. So we go to the home, we go to the park, we go to the hospital, we go where the individual wants us to be. We also have on staff nationally certified trainers in the field of peer support. So wellness recovery action plans, mental health first aid, home health action management, and we have state certified peer counselors that can teach the certified peer counseling course. So we do have that element.
Hi, my name is Dan Sigler. I'm the Regional Director for Pioneer Human Services. And Pioneer is a statewide organization, but here in Spokane, our primary focus is on working with people who are involved in the criminal justice system, who are re-entering the community from prison or jail. And we provide behavioral health, housing, and employment services. And so we work inside Geiger, and then as well as we have inpatient then we also have inpatient treatment, and then we have outpatient mental health and substance use disorder treatment. And so we kind of have a continuum from the jail out into the community, and then we have about 200 units of housing in the area, and then we also operate 2 federal reentry centers in the region for people who are returning to the community from federal prison, and we also have treatment programs embedded in those for both mental health and substance use services. And Pioneer is a little unique in that we're a social enterprise, so while we don't have this in Spokane yet, though it's my hope that we will do this soon, about 40% of our revenue comes from actually our manufacturing businesses, which then also provide jobs, second chance jobs for the people that we work with. So.
Hi, I'm Sarah Bullock-Dorn with United Healthcare. As Kat said, it's really important for us to be here and see all these community partners. We have a lot of staff internally that do outreach, that do care coordination, but we're really nothing without those folks who are our community partners, providing the food security, providing the housing, providing those services that are so critical to health. And so it's really great to be here with all of you guys.
Good afternoon. My name is Siobhan Vanahe. I'm here representing Providence Healthcare this afternoon. Much like Multicare, we're up on the hill. I think you guys are all very familiar with what we all do, but obviously we have our 2 hospitals in the Spokane region, Holy Family and Sacred Heart, and then our primary care clinics, 12 primary care clinics and 5 pediatric clinics. And we're just really excited to be here. One of our strategies is to really transform care and improve quality outcomes for everybody, especially that Medicaid population as well. Caring for those poor and vulnerable patients has always been our mission, and we really are really excited to be here. A lot of our partners are out here excited to make new relationships and to see this work grow.
Hi, Lindsay Rugi-Vivar. I'm the Director of External Affairs at Chaz Health. You already heard from my coworker, Mike Weiser, about the services that we provide. I just wanted to throw out there that we are always open to exploring new partnerships. So we'd love to meet with any of you. Feel free to reach out to Mike or I.
Good afternoon. My name is Linda Lauk. I'm with the American Indian Community Center. Primarily, my role is employment and training manager for the Indian Center, who's been in business for 50 years here in Spokane. But I headed up a development team for the Good Heart Behavioral Health Program, which is now up and running after many, many meetings and many weeks and months of hard work. We're new to Spokane. We hope to partner with as many people as we can so that we can provide the best services we can for our community. Thank you.
I'm gonna call over. Hi, my name is Kathy Richards. I'm with the Indian Center also. I do employment and training intake for the Indian Center, general assistance, case management for Native reentry, summer youth bills for kids, and backup support for everything that we've done.
Reese wants another chance, is that, no? If you raise your hand, it's, oh. So how many of you learned something new? Hold them up, hold them up. I want to see it. So everybody learned something new. I think that's pretty wonderful. And Justin just reminded me, we have a couple folks on the phone. So folks on the phone, hopefully you were able to hear those wonderful introductions. And so if you don't mind introducing yourselves to the folks in the room, we would really appreciate that. And let's start with April. Let's start with Amber, if you don't mind.
Sure. Can you guys hear me okay?
Yes.
Okay, great. Amber Moore. I am a director of Medicaid strategy for Kaiser Permanente of Washington. I'm calling in from Seattle, so thank you for accommodating. We have, I think, about 10,000 Medicaid lives that we serve. We treat as patients through our medical groups in the Spokane area. So definitely kind of interested in engaging in this group. Thank you.
Great, thank you, Amber. And so we're just going to go ahead. I want to give a sincere thank you to all of you. This is quite a time of change, and it has been a time of change for, I'm going to say, the last 4 or 5 years, if not more. But for some of you, especially the behavioral health providers at this time, going through significant contracting change at the very least. And many of you are just have continued to struggle with contracts, continued to struggle with financing, and yet here you are year after year after year, and yet one more leap, here you are saying we are going to be all in system transformation because we think it matters. And so when I think in that way, and I look around at all of you who I know your time is precious, I know your time is valuable, some of you, many of you are direct service staff, every one of you heard cats, and you all know what I mean by that. But here you are, willing to come here, willing to participate in the work, willing to pull up your sleeves and just get in and change the lives for Medicaid individuals. And they are the individuals that need us to change the system, right? So all of you are incredible leaders and visionaries, and really that's heartfelt, that's genuine, and it really doesn't mean enough. So thank all of you very much. It's wonderful to have you here. And all of you just met your new coworkers, and you didn't even realize it, did you? This is your new job, right? Yeah. So anyway, it's wonderful, and really appreciate each and every one of you standing up and saying who you are and what you do. I know that's extremely uncomfortable, so thank you very much. And we are going to put together some information in regards to your agency and what you do so that all of us have it, because I'm willing to bet there might be a few of us who didn't remember everything. I know Torney did, but I didn't. So that we can have that, because it'll be important as we go forward and we really start digging into this work, that you have a good understanding of what each other does. And I've heard a number of you say that you're looking at partnering and wanting to partner with others, and great initiative. We absolutely support that, want that to happen in our system. But how do you do that if you don't know what each other does? So again, we just want to facilitate that. We want to try to encourage any sort of natural partnerships that we can help facilitate. I love being flexible. Some of you know that about me. And so we're running just a tiny bit behind time. But time well spent introducing ourselves and getting to know our coworkers just a little bit. The next section that we were going to do is really talk about Medicaid transformation and why we are here. And these are primarily slides that we have gone through before, so I'm just going to go quick. And I see heads nodding, and I don't see any eye rolls yet, so thumbs up, doing an okay job. So we're going to go quick, and then we will provide these slides when we send out an email, right, and Justin's shaking his head, so that if you do want to review these, or if you do have questions, please feel free to always contact anyone here at BHT. We really are happy to help. We love getting engaged, and so that's why we're here. We have this vision of we want every person in our community to have access to the things that really fundamentally we should all have access to. Food, clothing, shelter, education, a safe community, all the access to whole integrated care, primary care, behavioral health, all those things that make our lives whole, all those things that give our lives a foundation for a good quality of life. So what are our goals? And you'll hear, I'm sure there's probably not one person in this room who hasn't heard, and I'm going to call it a catch term or a catchphrase, but the triple aim. And we've been hearing about this not only in our region, but across the nation. But it comes down to better health, better care, and lower costs. And we've all heard, because we're smart people, you're smarter than I am, so you all know more than I do, but you know that in America, we're really needing to look at the health system and how we provide care and the cost of care. And so again, coming back to that idea of here we are at a local level, and gosh darn it, we're going to make a difference, right? We're going to end up in the New York Times. That's my goal for all of you, so hope you do a good job. So, and again, this is a redundant slide for some of you, but just kind of giving, again, a little bit more of an overview. And we're really focusing on some target populations at the bottom. Most of you, I believe, have studied your Medicaid transformation workbook, and you probably know that this is on page 39, right? Yeah? Okay. Just kidding. I don't actually know what page it's on, but and then we're going to build a regional infrastructure, so that's all of you working on all these areas that I have heard each and every one of you say something about. What about workforce? What about payment reform? In fact, I was having a conversation with someone the other day just about, I think it was you, Tony, about policy and advocacy and how can we do that? How can we come together and change a system of care, really push towards transformation and integration if we don't do some of this policy work, which some of you remind me on almost a daily basis. We can't do that per a whack, or we can't bill for that, or there's no code for that, right? And then where are we going to transform these settings? Where does transformation happen, which is at the top? And that's all of you folks, every single one of you. I'm going to just skip because I've got the clicker. It gives me power. Really, and one of the things that Allison's been talking about, and it's really come to fruition as we start working closely with the managed care organization. So if you recall, in 2021, 90% of managed care organization contracts have to be in a value contract with providers. And in that 2021, 50% of commercial plans have to be in a value-based purchasing contract arrangement. So it's not just Medicaid, because I know many of you also serve commercial or are looking to serve commercial. So we really want to support that. We want to support the system of care. We want to make sure that not only are we transforming the Medicaid delivery system, but that we're really supporting the health of organizations who do that. Because if you're not a healthy organization, you're not going to, your clients aren't going to be healthy and the system isn't going to be healthy. So that's kind of the premise of another reason why we're doing all this work, is to have a healthy system of care, have healthy providers, and really support you getting to that place where you are just as much of a player and a sought-after player as everyone else in these value-based contract arrangements. This is a wonderful HCA slide. Talks about moving from a fee-for-service, again, with the value-based payment, to more of a bundled and a capitation. And I suspect at some point along the line, we're going to take a deeper dive, but this is just an overview for today. And so with that, many of you came to really get a deeper understanding of what is the collaborative and what is my role as an organization and what is it that this collaborative thing is going to be doing. And so oh, you've got your own mic.
I think I have.
So we'll just, okay. So with that.
You gotta stay away though, because we might
we're going to
get
echo.
weird.
So with that, we've got Allison Polson, who's our executive director, and she's going to do a wonderful job of explaining it so clearly that none of us are going to have any questions.
Well, as long as we have the 17 slides that I laid out in the matrix form for each of the key areas that we will walk through, which I will read to you each of the elements, it should be perfectly clear. No, I'm just kidding. We have broken this out into several sort of chunks of key work, and I am not going to actually walk us through every single one, but we want to try and differentiate what is the role of the ACH. And sometimes we say ACH and we mean all of us as the collective, and sometimes we say ACH and we mean BHT is the backbone entity. For these purposes, the ACH is BHT is the backbone entity. The collaborative, so that's for Spokane County. We also have a collaborative in each of our rural counties. And then the provider and partner. And I think this is where there's a little bit of confusion playing out. So if we took governance, so it is the job of BHT to develop a multi-tiered, multi-sector, multi structure to really govern the Medicaid transformation, both the work and the money. We're under contract with the healthcare authority in that way. So that's sort of our job. So we created this structure, these collaboratives. We're starting to work with our Medicaid transformation project plans, and the board says, yes, that's a good idea on behalf of the region, and then we roll things out. I'm going to skip over this collaborative section to start with and go to the provider partner, because I think this is a really important part of where we're at in our process right now. Each of you, on behalf of your organization, needs to figure out how do you fit in this Medicaid transformation space. And you need to be thinking about it in terms of what's your business model for it. Because while initially we were talking about $1 billion, it turns out we didn't get all $1 billion. It has to be shared across the whole state. So all of a sudden those dollars that seem gigantic are helpful, but not enough for me to pay you to do things that don't fit within sort of your overall business strategy. So from a governance perspective, we really think you all need to be thinking about how you're going to participate as it fits in your organizational strategy. We think that while everybody has great intent, it's possible that if we approach this by individual providers, we might not actually get to a cohesive system, either at a county level or more importantly as a regional level. So we really see the role of each of the county-based collaboratives being sort of responsible for looking at, are we going to be able to move the needle with the right set of partners in that way? So there's a bit of a governance structure that will have to come out of this group that allows for, on one hand, I'd say sort of the community negotiating. Are you going to take 10% more patients that have this characteristic, or can we invest some additional capacity over here, or what are those kinds of things? So we really see a high...
You're standing in an echo spot is the term adjusted.
It's a technical term. I'll be on this side. I'm all off. I don't know how to gesture right. So we think there's some role as both a collaborative where everyone is sort of at the table, and likely you will decide you want a bit of a leadership structure to figure out how to facilitate that, that forward. So I think that's a good example of you've got your own plan in your own organization to figure out. It's my job to make sure I'm setting some structure so you can do that. And then this group is really at a collaborative level. How are you going to negotiate to ensure Spokane County is really well positioned to meet those goals? So I'm going to pause there because I think governance is a little complicated and see if there are any questions. Otherwise, we'll move to another target area to talk about. Great. Must mean I was so clear. Next slide. Let's take fiscal management and accountability. Because at the end of the day, if you don't have the money, it's really hard to be transformative. So the role of the ACH is really to develop and manage the funds flow process. And we're doing that through a very community engaged process through our waiver finance group. We've got 3 sort of core buckets of work that we're working on. The board approves the funding model. So as we release all of the MOU, and you could see I can earn this amount for completing the MOU, and this for completing my assessment, and this for my implementation plan. That was really our job to develop. I'm going to flip back over to the provider partner. Each of you are going to have to decide, is that amount of money worth the amount of effort that we're asking you to do, and what the longer term role is. So there's a very much a individual provider decision point in terms of participating in this Medicaid transformation work. We are so hopeful that most of you, if not all of you, are really committed to this work, and that we figure out how to ensure enough financial investment to make the kind of changes that we're going to need to make. And as we are going to just keep coming back to, at the end of the day, there is not enough money for me to sort of subsidize your efforts. It's got to fit into your long-term financial plan. And for many of our providers, it's really, as you move into value-based payment, there's sort of this window of time where there's going to be some investment and some partnership development, flexibility, and then, you know, the new reality comes into place. At a collaborative level, we want to ensure that, one, that we have just representation from every one of our collaboratives on our finance work group, which we do. So we can all check that off, so that as the collaboratives are developing, we ensure that every collaborative has a voice in specifically how those dollars are being allocated. The other thing that we see happening at a collaborative level is really looking, as we move through this implementation planning process, at where there could be shared investment based on the fact that there are 17 of you who need this type of training, or there are 11 of you who need this type of service, or if you have this, it would affect 27 of you. So we really think some of that negotiating, once you've figured out your individual organizational sort of capacity needs, comes together to create a really cohesive approach. So that's a good example of where we see the difference between those three roles. Any questions about that? I am going to move into, we keep calling this data and shared learning. I'm not sure there's really any shared learning here. I think mostly there's going to be data and frustration. But, well, I think shared learning just seems so lovely. Part of the role of the ACH will be synthesizing the whole host of healthcare authority data that is coming to us to ensure that we're sort of moving the needle on all of our priority areas. And we imagine through the implementation planning process, we're going to identify a number of capacity gaps that exist in the system that we're going to have to address. And those may be very specifically on how can we report on things, and it could also mean how are we talking and sharing information across multiple sectors in multiple ways. So the ACH will sort of be responsible for aggregating needs and helping to develop a regional plan. That regional plan will really be influenced highly by what the collaborative sort of negotiates that they need. And that at a county level will be informed by what individual providers are really putting in place. I am convinced I could spend every single penny of the transformation dollars on data, and none of us would feel satisfied. So this is really, I think, going to be a large effort to try and, one, prioritize what could we actually have impact on, and two, how are we trying to get the best amount of leverage of our dollars to go the furthest point forward. Questions, comments? Is it kind of making sense, the difference in potentially how this collaborative structure could work? Part of, I would say, a little bit of resistance on my part to go too deep into these roles is we do not think we have the right answer to tell you this is how you all need to organize, and that we have, oh, I don't know, 4 years or so left of this transformation effort. Actually, no, it might be 3.5 years. And at the end of that, I have no money to keep sort of staffing you all doing this. So one of the most important outcomes of this collaborative work is we have actually built these new sets of relationships. And I keep thinking about sort of that muscle of collaboration in that way. So we are happy if you tell us, gosh, we need more support or technical assistance on any of these things. We are happy to come forth with some ideas and some structure for you. But more than anything, we actually think this is an important sort of community leadership moment for our community to figure out how are we going to work together. So these are sort of our thinking of that thrust of how we envision really the difference between your job as an individual provider and the system of care we're trying to create. Comments, questions? Okay. Should I do one more? I'm going to do policy because Tony's sitting right in front of me. And because increasingly, I think this is going to be sort of an unfunded part of our work. And that I have personally sort of shied away from the idea that we're going to go and try and change policy because I was thinking, oh, it's money and we're going to just be able to figure it out. And I don't think a conversation goes by that you don't understand there is some less than helpful policy that is in place that probably was put in place with great intention, but maybe does not help us get to improved community health. And that we have really assembled this really interesting set of partners who maybe don't collectively go to the legislature and ask for things very often. And that if we started to get aligned on some of these policies, that you see the effect on healthcare or housing or on food security or education, it could be a really interesting new set of partners to move forward. And you add to that, Spokane has historically been incredibly effective and disciplined at sort of aligning around some core issues and then holding our legislators accountable to moving things down the pathway in that way. So I think we would see our role of identifying what are these policy changes that we're hearing and trying to sort of organize ourselves in that way. It is going to be critical that we start to build a set of policy agenda processes in place at an individual provider level, and really then aggregating up at this collaborative level to decide going after this policy this year is going to be more important than this one, which is always the hard part of how you hold coalitions of folks together, because you've got to, there's only so much bandwidth, there's only so much interest, and obviously only so much money that you can affect at any given time. And so that's, again, where we think this depth of relationship has a tremendous amount of opportunity at the collaborative level to sort of form some interesting new ways for us to push on policy. And we suspect that the policy issues we identify here in Spokane will not be unique to Spokane, and that might be true if you were in Wenatchee or you were in Seattle. And so for the first time, there's sort of a multi-sector set of mechanisms in place across the state to help move that forward. So it just feels like another opportunity for us to be thinking about. Is there one more slide? Oh, I should do something here. So I think we've sort of hit on the project planning and implementation, really at a local, individual provider and partner level, that role. I think that let's just take workforce, because I think as we rapidly move into, here are the system changes we want, we're going to figure out, wow, we do not have an adequate workforce to move that forward. It will be BHT's job to really aggregate across all of our implementation plans some identified areas and gaps. And I think there'll be sort of two pieces of work for us in that way. One is working with the other ACHs across the state to try and push on, are there ways to really think about workforce development across the state? And then I think secondarily to that will be, can we use sort of our local workforce development infrastructure to target some very key areas in the short term? I think the region has a great long-term workforce development plan as it relates to healthcare. I think we all can acknowledge what an important role healthcare plays in our overall economic vitality. It does seem like they're sort of missing the 1 to 5 year plan in that way. So I think we play a role in that. I think it's going to be really important in the implementation planning that our individual plans really are addressing what am I going to need to be ready for next year when we move into integrated managed care and some of the clinical integration work. But what do I need to be thinking about when we're moving into value-based payment as the primary way most of our contracts are being developed? And what's the innovation piece? I think it may be easier to sort of say, well, this is my ideal. Can we try and fill that gap? But where are we starting to drive some of that innovation, whether it's with telehealth or lots of, I think, cool ideas around residency programs and practicums based on the university systems here in place. Consistently, I think we are going to expect that the collaborative structure is really coming back and looking at where is the most valued investment that we're making, and that individual organizations are going to have to figure out sort of how to get into the mix in here, but also what's the negotiating we're going to be able to do. So you're kind of getting the sense that at the collaborative level, you're bringing like, this is my perspective of what my organization needs to really thrive, and now I got to figure out how does that fit across similar partners and, you know, oftentimes competitors in my sector and across the other sectors that will be necessary. Okay. I feel like I've done the roles. And don't have a mic. I know. We're here to do.
So we did want to leave some time for question and answer because this is a lot of information. And even if you have questions about now what is it the heck we're doing, you know, it can be anything. So are there any questions? Or are all of you thinking if we don't have any questions, we get to take a break? So we've got one honest person in the room. How about this? How about we take a break? Maybe you think about some questions or not, and then we'll come back about 2:30, 2:35, because I know this has been a long stretch. So let's take a break and relax for a few minutes. Thank you.
I wonder if I got tired. Right? Oh, it's good for me that I know. Like their own herd. $10 worth a quarter. How crazy I am. Every time I come down here, we actually have through our billing and compliance department. I wish there was another billing through our EHR. Making great progress. I was actually
They're one of the few that have a very big connection, so they're less negative.
Actually went up when I had a run out of quarters.
They don't know.
Yeah, hey. Right in the corner.
That would be really helpful.
What do you guys think about that?
Right, yeah.
So we have to do a little bit of
Yeah, if you ever wanted to come up and
I think we are real. We're going to do the window. Keep the window open and point in the right direction.
Tier 23. I'm not a big fan of change. Didn't you go and then come back?
When we get how
everything's always the except right now where everything's shaking. I don't know.
That's how you got connected.
Yeah, and then so, yeah.
Yeah, so we're looking through right.
Oh, yeah.
No, that's fine. We are really complicated. I think I know people who decapitated back in and they put in and not have to this. You must have ideas on there too.
Because the grants are different, the funding is different. Right.
That's why.
And things you just did as part of your program, now you have to capture as encounters and find code. And
So I was like, well, really sad.
And frankly, if I'm a medical provider, I don't want to figure out if you've got
They don't have to worry about that.
So I don't want to know about your behavioral stuff. I just put it in the questionnaire that I need to know.
You know,
And I think it's too much for behavioral health providers to be talking to people about their obesity and their blood sugar management. It's not what we do. We're working with trauma. In the Medicaid population, we're not even working with personal care. We're working with crisis. We're not doing therapy. We're just trying to get them not to kill themselves. And why would we throw those in? Right.
Numbers are legitimate, real, within reason, and
I mean, it's a nice fantasy, but I have never been to a doctor who ever asked me anything about how I was feeling. It's just what hurts today, and sad, and awesome. Like I got two people waiting.
And she did the average of the final and I thought,
No, because if you know anything about violence, you don't.
Because I tried, and that sounds good.
Yeah. Just have to make it to the magic 70 when I can get the full Social Security. Because when you work for nonprofit your whole life, there's no retirement plan. So, and we're not ready. Have to get it to 70. Or have someone rich die. Or have codependent children. I just have a son who has really good boundaries. He's not going to be wiping my butt. So, which is a good thing.
Yeah, I think
Yes. Go ahead, live your life. Be a healthy person.
And they hate how we build it. Yeah, well, all of them do. But
Now that I'm getting up there, I've started reading about long-term health insurance. Like, oh my God, your kids.
The other, I bring, we have like 4 or 5 years,
So you think that would motivate people to exercise?
Decision making.
Can I get over that?
But I that was just way more. Yeah.
And Netflix now, whose idea was that?
I've never been or email me.
You need to get on Danielle's train because she teaches stuff like that.
I have a DOR. I cannot miss.
No, it's a good place to live. They don't have hurricanes and tornadoes and giant
Yeah, I mean,
snow things.
it's a big list, but we'd be happy to share.
No, I'd like to live on the East Coast. Oh my
I
God.
live in Texas. I'm right here.
I wanted to change my friends. I wanted to move down to California.
I was married to them. They can't get a certain level of security.
I moved to Texas. I couldn't afford California.
Yeah.
Oh my God.
I was like, okay, so where's that?
Let's die in the winter.
No, I was in the Yakima area. I'm not, and they do like primary
Yeah.
like they were like very amazing platform. I had no grass, but then having a facial section like that didn't work.
This is the place.
Yeah, well, and we have motorcycles. You looked at them too. Yeah, they're pretty reasonable. In fact, and their small programs. And I just I already have like anxiety, and so like they don't complain about it any more or less than our other programs.
It's a TV show.
Yeah, that's all. So look, I mean, it was really good for my employer. I worked for a major forensic hospital. Well, technically, it's one of the. And I'm just my compound. Yeah, I did.
And it gave you gratitude for being here.
It really, it's what I needed to appreciate.
Oh, this is.
No, and I love the Four Seasons.
Yeah, I do too.
You know, I live in Spokane, right up Spokane.
There's those devil worshippers, but
They're gone. Oh my God, somebody about that.
we don't go to Hayden because, yeah.
The devil worshippers. And
If they come out on the freeway and they stand in front of your car and you stop and that's it, they eat your brain.
no, you need to come have lunch with me.
I've heard the burger joint,
And then we have and that's like and is really big. Oh, is
and if they were, you wouldn't tell me anyway because, you know, you're one of them.
No, she was coming out from the mayor from. She's trying to get me to play with her here. You know, I'm the anomaly. Make a TV movie about how crazy I am.
Only if they're devil worshippers. Otherwise, we watch it.
Oh, really? Yeah, but I'm I had my brothers, I drive
Yeah, as you say, he's not driving out of work. And we had a fire season. Yeah, I'm done. One night there was a snowstorm and I wasn't able to get home. But until like
And we need to
in the morning is when you get up. Or people shooting guns off as soon as you get to work.
I would say, well, we've been promoting.
Yeah, the city's nice. I hear church bells and children.
Yeah, that's let's get together, even if it's just half an hour. Yeah. Okay, perfect. Sounds like a deal.
Yeah, she's got some siblings that that's gotta be tough for siblings to lose their mom.
I just had lunch with her.
We're not wearing anybody right now. I mean, so we do everything. We did everything. So we really all the time. But we talk to yes, we don't have it. And she's in there. Do you think Martha smile? Or he would have given, stuff. But that's the one impression.
Oh, yeah, that's right. Well,
And you buy it your desk? Yes. I mean, that Renzo is
they're my temptation. Yeah. And that's the thing. I didn't eat anything yesterday. Not breakfast. I don't. And then I ate dinner at 10:30. That's really dumb because I mean that's the choice you make, right? Your body goes in hibernation. I'm tired and I hope you're doing it. That's not a word. No, I mean, but you know what I mean. Like the extra cars. Yeah. I like feeling. Yeah. No, I mean, that middle organ fat. I don't know. Like, yeah, my son's so I'm just glad that now, yeah, you still enjoy your every day. My awesome Lilia says every day in every way. We share with them. We have a friendship. Okay, so I had not very long. So I can take yours. I can now. Well, I don't know what she is. And it's healthy. I would like to 5 years or something.
No,
my neighbors
there. I used to go out to feed the horse, and I'd have to wear like a giant moving blanket belt around me because that thing would come from wherever it was.
I think I have to get contracted for the care coordination.
Yeah, they're probably 6 years old. I did. After, I think about 3 years ago, we had a fire season where I came home from work and there was like a voicemail saying, "You must evacuate immediately." And it's like, when did this come? And I just thought that's done with the snow and the roads not being plowed and so far to drive. Where's the plow? You could go. No, it's like you could go out to the Air Force Base and then other people come in and walk like you. And everybody's like, but isn't it so nice to have a long drive after work to just, no, I want to be at home. Now it's 15 minutes and I'm just like,
if they would have come by.
It was a fun idea at the time.
At the same time, they would have said, oh, you've been here too long.
Because, you know, sometimes I have no car
Yeah, if you don't have milk, you just don't. You're not going to get it. Right. And if you have a health issue, where will the helicopter land? You know, when you start getting older, it's like, if I have a heart attack, I'm just going to die here because it's a volunteer fire department. I spent hours and hours at soccer practices just sitting in my car because I couldn't go home. I would just sit and read a book for hours and hours. So it was good to experience it, but
I don't know yet. They don't know what the outcome is, but
That's what I heard.
well, you have to have a set of standards. Here,
how are you?
They need to get back. They need to figure out where they want to. And part of it is like this time we said not fast.
I don't know, something else. It's like, it wasn't something happened like that with us too. I think so. Because when I printed it out.
Okay, folks, if you don't mind getting settled again, and we'll finish off our day.
Because I sent it all the things. And the director, she had made state advisory board because I made a contract.
Because we have a disproportionate amount of native kids in foster care. Let you know that might be showing up in your radar.
Okay, folks, if you don't mind getting settled. This is the cat herding. And we have a troublemaker from coordinated care. Not going to call any names. And we have, my boss is going to be in trouble. Yeah. But she does sign my paycheck, so we'll keep that quiet. Carol's causing trouble, but she's just waving me off, so. I want to say two things before we step into the questions. So at the end of the day, when all of you folks are heading out, we're going to leave a sign-up, not a sign-up sheet, but a sheet at the table where you signed in, where you can add your email addresses if we didn't get them. We know that some of you, your bosses, perhaps forward this on to you, and we're fully expecting and fully wanting all of you to be involved. So if you want to leave your email address, we'll make sure that we'll get you included. And then we had just a great comment from our fire and EMS, Mike Lopez, who just was like, I can't believe all these people came. Like, I can't, he said, Sharice, I can't believe all these people are in one room and how phenomenal that was. And so again, just more credit to all of you for taking time out of your day, and how big and how important this is to many of the partners we have in Spokane. So, and with that, we had Kat come up from CHPW, and she might have a question, I think, right? Kat's pretty smart, so when she has a question, we should probably all be worried.
Well, my question was actually a question back out to the group. So there was some sort of silence and thoughts. I think everyone was pondering the different roles that Allison was laying out. And I thought it might be helpful to sort of reframe, and if people would reflect on if they saw themselves in what the roles were that were laid out. And did that match your expectations? And if so, what matched those expectations? And if not, what might you see as different with respect to the roles that had been laid out? So it was sort of more of a question back to the larger group.
I'm gonna let Kat keep the microphone, because I suspect that as I pick on people around the room and ask you to answer, you might want to say, Kat, now what is it you want again? All of you have a microphone, or most of you have a microphone in the middle, in the center of your table. So I'm gonna let the holder of the question have the big microphone, and then I'm gonna pick on our friends from Aging and Long-Term Care first, to answer. Repeat the question.
So we might want to pull up the slide again. That would help. That has the roles. And so the question really was, as we look at the different roles that are laid out for provider and partner, the collaborative, which is what we're initiating today, and then the role of the ACH, but as Allison said, Better Health Together is really that backbone. Do these roles reflect what you expected? And if so, what about it reflects that? And if not, what would you want to see different?
Okay. Well, it actually does fit my expectations, which is probably a good sign being on the board. So that's a good check mark. That's number one there. And for us, it's looking at, okay, for the Medicaid patients we're serving and clients we're serving for all of these different programs, how do we take what we're doing and making sure we're leveraging it as part of this initiative and as part of this group? So figuring out where we've got connections, where we have common clients, where there's work and there's gaps to do, and we know and we see them all the time, and how do we come together as part of this effort, not just with the work we do internal and we, do day to day from hour to hour, but figuring out, okay, how do we help be a part of moving the region? And I think as far as the provider partner, it really does help. Okay, this is what our role is in this group versus the broader ACH framework. And kind of the ACH is kind of this is where we come together, kind of guiding the process. But the collaborative really is okay, this is where the rubber starts to meet the road, but it reflects more on what are we doing as an agency and how do we figure out what things fit within our own agency processes and priorities, and finding those points of collaboration.
Great question, great answer. I'm going to pick on our friend Dan, who I haven't seen in a long time, from Pioneer. You knew that was coming, didn't you?
I think that this fits pretty well with kind of what's been being presented up to this point in a lot of the meetings, and so none of it seemed real surprising to me. I think there's still, the question about where the rubber meets the road, I think is probably probably that point for a lot of us, thinking of how do things, or maybe it's just me thinking operationally, how do things eventually operationalize into things like agreements and what services are actually going to look like to be integrated and all those different pieces of it. So
we're doing okay so far. I'm going to head over to this side of the room, and perhaps we can get an MCO perspective, and I'm only going to pick on you because you were a tough cat to herd. So
I was trying to solve a provider problem.
Exactly. And then, no, I'm working on it though. Don't worry. I have to agree, to me, it looks like it's pretty thorough and what I would expect. I don't have a good answer right now, I'm sorry.
You're okay. You're a good sport for letting me pick on you, actually. I'm going to squeeze through here, and perhaps we can get some thoughts and perspective from Planned Parenthood.
Sure. I think this all looks really intuitive. I think the place that we would be a natural fit is with the policy. We have a pretty well-developed policy program and could help with that.
I'm going to pick on one more person. I know, as I walk by you, there's a sense of relief, isn't there? I'm going to pick on one more person, and Reese from Department of Health doing her TCPI work with her mouthful. So perfect candidate.
No, I think it's really, really exciting as I look at it laid out. I've had it told to me by ACH staff and by community members, and we've had conversations, but to see it laid out like this is really, really exciting, and it really aligns with the work that I do within the clinics. Is really getting them ready for this transformative work, and so I think I see a lot of partnerships in the room. And one exciting thing when we went around, just as a side note, I'm constantly going to these other collaboratives, and I have to stand up and go, and kids, but I see that they're well represented here. So I'm excited to see what happens.
Is there anyone who just wants to I saw 20 move. I'm not sure if that's a volunteer. Do you want to? Oh, great. Didn't think that would work, but we'll do it. So I got my Fitbit today too, so I'm getting my steps.
Thanks, Sharice. From my perspective, the roles fit fine. My concern is that so much of what we're doing is around the Medicaid dollar. And from a public health perspective, our primary interest is about the health of the population. And I'm curious how each of us will think about involving prevention in the work we do so that it doesn't ultimately all become about treatment. I heard Tony speak about that in the things that she reviewed, that they spend a good deal of time on prevention. If we really want to make a difference down the road, and it may not happen in the 3 to 5 years of this grant, we have to focus on that as well, and a lot of it won't be reimbursed.
Great, thank you, Tony. Is there anyone else who would like to say something on Kat's great question? Okay. Oh, yeah, we got one more. New Horizons.
Professional personal perspective is on the community gaps, where we're going to be able to find the gaps between these services, moving from the physical health into the substance use, into the behavioral health, into the housing. So being able to find those gaps and fill those gaps. And I think will also help address Tony's concern on the prevention, but being able to treat and fill that gap, potentially prevent additional services later down the line.
Right, and I think that's a perspective. I see heads nodding, so I think that's a perspective and an interest from all of you. And again, everybody in this room is a subject matter expert. You're all leaders. You're all extreme visionaries. I know many of you. So I absolutely believe that that's part of the work that's just going to happen organically and naturally, and has to happen in order to make some differences in the transformation work we're doing. So great. Any other comments on Kat's great question, or are there any questions in general? So I'm just going to open it up. Is there something, any questions that you have just in general? It doesn't have to be about the collaborative or.
So this is probably directed to Jenny. About the care coordination, planning, and implementation. Can you talk a little bit about that project? I got some handouts, the target population is, and how providers in the room can get involved.
Wow, you didn't see that coming, did you? No, that's great.
So for community-based care coordination, we just launched the Council Hub, or Hub Council, for 2018, and many of your organizations here in the room are a part of it, thankfully. And if you're not represented on this council, please get a hold of me, email me, call me, and say, hey, we feel like we should be a part of it. We want as many sectors represented on the Hub Council as possible. What we've identified for 2018 is focusing on jail transition, those transitioning out of jail, to provide them access to behavioral health, housing, education, all of those different pathways that in the pathways model that we've identified. Our first part of the work that we anticipate is really trying to get a good grasp on what is happening, what are the successes, and trying to align as many of those activities in the region here in 2018. 2019, we'll be looking at expanding the target populations into high-risk pregnant moms, and then into eventually helping or reaching the target population of chronic disease management. So does that help?
Thanks, Jenny. Appreciate that. Thank you for just stepping in there. Any other questions so far? Okay, we're doing okay. Justin, you want to pull that up, please? So we're going to have a little bit of discussion, and I just have a sense, and we just have a sense that there might be a little bit of concern about being part of the collaborative, about being part of this Medicaid transformation, about working on some of these projects. So we're going to make things a little bit comfortable for you. You can stay at your tables, but within your table, we would love for you to have some discussion with your partners about what are your concerns. What is making you anxious? What are your concerns about this process or being part of this collaborative? And then that discussion then naturally leads into, well, maybe here's some ways we can handle that, or here's some ideas, or have you thought about, or this is something that we need to address as a collaborative, or this is something that perhaps BHT can support or assist with. So that's your task, and go.
Hello, everyone. I'm concerned. Remind me where you're from again? Currently with the WHO. There's nobody in the room. Where's Joe? Who wants to start? Where's the collaboration with the WHO? I think so, and we're already having problems with our system with them. Now I'm seeing a not saying you're not working, I'm saying you don't know what's Exactly. We've been having this problem forever.
What do we really do?
From
That's all we do. But, there's those years before. We have a program to do stuff like that.
Aren't they the partners in those two?
Like I said, we're brand new. What kind of, what I read?
Oh, that's a huge concern for us.
We all
exactly. We are
I think it's involved
for the research.
But I would say a whole year working with the WHO and the healthcare authorities and getting figured out and still don't have it right. And then I just say it's getting better until you guys there's some sort of
really look back to the conversation.
You know who they are.
Code word.
She brought up a number of points that.
Well, and how do you prove how can you prove that
well, you guys yeah, this was January 16th, and Monroe came out from New York to the co-chair of their project.
Really, it's a big mess.
There's 25 different agencies. Some of them literally
you'd be running away with
she mentioned a number of things that there were potential, there were problems.
One of my concerns is
familiar with SBO or Carologic.
Anyway, so that's.
So one thing that yourself
they've
done, a big thing that I'm part of. Scott Davis, yeah, Scott, Andrew and I, and Ryan, who was taking this. So we have negotiated with Carologic.
I don't see two people.
But I really.
So that's how
we spent a lot of
figuring out what
time
they're
over
doing.
there.
Yes, the reason why we
Just like you said,
Looking at that different art, who all the providers are, and
people that make
but they haven't figured out the household. Even though it is.
and it's like, okay, those
with that process,
that
they applies to
really well taken care of at the expense of
Given the limited amount of
you just keep moving forward.
Yes, it's a lot, well, you can do it separately or together. So they-
Where do you have to get it? Or how bad?
The reason we signed that MOU, we're actually yelling all the collaborative.
I'm here from
So I literally those ones that I go home to, I'm collecting data, what some of the EHRs are doing, those ones are planned, and so in Southwest County, every provider has their Valley.
I think we're critical. Do you guys have population, do they see them helping health providers?
Originally,
We have the HLA platform, that we all got it ourselves, but then all the data was upside down or whatever. I like, great. And now that whole. Yeah, so, how do we make sure that those, population providers?
Yeah, and I know that
Have, like,
they'll
know who the folks are. Because otherwise there's a disconnect. This is where, how do I pay this money?
Carologic,
Everything put in housing. There's no way.
But to how we can collaborate all.
I'm sure that
you have all these different integrating here. Why we're in that. If you're all serving the and then the SBO needs data, but you need someone to know that it's actually. So if you're going to talk to a payer, it's a voice, which another meeting. Actually envisioning.
Oh, I love it.
Yeah, so there's coming up.
I didn't know that. Yeah,
Change the date. So it's going to be a web-based meeting. I don't know if you're.
And
they have, and what they have. You go to the business card, I'll put you on there, and I'll change
What shares to make.
4th and 11th Thursday. Yeah, it's just a web-based meeting.
Medicare.
Andrew's supposed to be doing it.
That was something that had to work through.
Yeah, and so there's April 2nd, there's one option.
Yeah.
It's a 15-minute, it's a 45 minutes. Just like, so, Carologic, explaining a lot more than more the process.
So then the question is,
We always have to do that.
Don't know if that's.
Yeah.
These are the hurdles.
Carologic, it's just like it sounds, CARE, logic. Yeah, and then XPO.
Getting those, I mean, it's those gaps.
And they XPO created the whole, you're going directly through the loophole.
How to get from here to where we really should be, not Nirvana, but I mean,
they're from
without the big fear of,
anyway,
next Monday, I can tell 30 people they gotta go home.
What's your email?
Help, I know.
Yeah, because I have on my calendar today and the meeting notes all the work out.
I wonder, because I did not have the 10.
Yeah, okay.
And a lot of that is actually
Blake's very familiar with what we're doing. Yeah, so yeah. Yeah, it's just.
So are you gonna say, is someone, you know, someone gonna be our spokesperson?
They have the billing software attached to it. They're, you don't have your own ID. They have a whole ID. We don't have to do the same.
So that's again all the. Yeah, but I'm just, a lot of our houses start out these full, like in the school systems, which, if they're not, if they didn't opt into PHO and they have a service card or whatever they call it now, they won't provide services to them, and that is discriminatory. They should be able to get it anywhere. So we ran into that there. What was it out?
A well-established group with a good workflow.
There are ways, it's a matter of kind of unlearning ways, moral patterns, that behavior that aren't good anymore. So they become that target. So for that, you know, and then in our behavior, and also medical. Partly, I think it's partially you have to unlearn medical. Well, so there's like those many layers.
Because if you can't get,
we need all these.
come in and start with we can't send our kids.
And you know,
I don't mind. And
just saying.
And just, I mean, ain't nobody grabbing the left. You know, people sitting around going, well, I wish I could play a little less Tetris and do more. I mean, we got people just
smaller groups of people not it. For them going to the world as well. That's the difference. Is you've got it's easier to collaborate. Whereas everyone's doing a lot of different stuff. So
yeah, it is.
Yeah, I know.
Yeah, that is the risk of group.
Right.
I mean, that's a big question.
Right. Just well, kind of like EHR, that's almost like EHR 2.0. I know when I was filling out some of these surveys and stuff, like you have the ability to send encrypted information. We do, but not like from provider to provider. And you know, like I know my kids, like my kids' pediatrician, I get them to send them a message, and then if they need a referral, they can send it on to whoever. You're like, there's ways of doing it. And I think we got to all be on the same page first. And there's tons of stuff that they can develop. I mean, it's kind of guys at first getting using. And the nice thing is because the software is all being developed for us, it's not like we're buying something native. Right, or something that's meta. There always be the issue with usually.
So it's that's where I want.
Yeah, I think the only exception to that is the best. Well, but yeah, they need to see that when that's something like that. It's all meta. Get us going with our problems.
There's no contracts going out there.
Yeah, well, it's cool. And it just, I mean, it's not like
Okay, folks, I hate to interrupt you because I get the sense of a lot of good discussion, but Justin's telling me we need to keep on track time-wise, and he's my boss today, so I'm gonna let you have 30 more seconds just to kind of wrap up your conversation. You will need to be thinking about, I want to hear from each group, so the shyest person at your table is what I'm saying, but you guys can decide that.
Wait a minute. For instance, we do have children. We have rested beds, so people, almost when they're coming out of hospital, have more time to heal, come to a rested bed at home. They get 3 meals a day, they can stay there. Provide them medical care to come into the shelter and work with them while we work on rehousing. So the shelter currently operates at about 47% rehousing.
Yeah.
So pretty high, that's the issues, and we're also
this as like
working with Molina for contract.
The Fairfax one?
Them to bring.
We talked about that.
That's Fairfax. Yeah, Fairfax Providence.
No.
How they do it.
Proactive. Figure out how.
Behavioral health.
Oh, it's just another type of.
They're getting less of them coming back into the hospital within 30 days. They chose to do a lump sum at the beginning there. They could either do a per night rate or they chose to do a lump sum at the beginning of the year because they have 6 beds available to them every night for the entire year. And so what's the nice side of that is working with them was that they're having a bed and not utilizing it. We can get a
Well, individually, yeah.
It sort of depends on the situation that we're dealing with.
That's my biggest concern, because we're dealing with a Medicaid population who are chronically mentally ill.
Okay, folks, I think there's some great discussion going on, but hopefully it's coming to a wrap up and ready for a report out. And I'm going to just move to the back of the room and have this wonderful table kick us off. So if you folks don't mind doing a report out on what your concerns are about being part of this process, and then how are you going to solve the world's ills, I think was part 2 of the question up there. So
That part.
We are.
It involves chocolate for sure.
So we had a good conversation about not just the work of the collaboratives, but then what comes after that and what the future looks like. But one of the things that we kind of settled on towards the end was how do we collectively, for all the people in this room that represent how many different sectors and unknown faces and whatnot, how do we collectively come up with priorities that all of us can rally behind and get behind and support and kind of move forward. I forgot the second part.
You didn't solve the world's problem.
No, we didn't. We didn't have enough time.
oh my gosh, if you would have had 30 more seconds, you would have solved it all, wouldn't you? No, I think that's probably, I'm just going to guess that's probably a concern that others have had too. So great, thank you.
Who's the shy?
The shy.
I'm not shy, but it was by default. So, yeah, one of the things we talked about is this is a huge group. It is just a massive group of organizations with so many different things that we all do. And I think even if we couldn't spend maybe a whole week and if we had presentations from every single one of us on what we all did, we would probably never make it through that. And so it's how do you deal with this massiveness and get to picking priorities? How do you actually move priorities? How do you come together? So we talked a little bit about maybe the chair, co-chair that we've used in other groups might not be sufficient. We don't know what else it'll look like, but we figured this is a good group to figure out what else we need to do. There's also some talk about just the making sure beyond this process that clinical and social determinant of health partners come out with really clear linkages so that when this funding goes away, that people know who each other are, how do you make referrals, what are appropriate referrals, making sure those partnerships are in place, because that's a lot of the long-term sustainability and change that's going to come, since we know so much happens outside of the medical system to impact people's health. We talked a lot about who isn't at the table. Is that part of our role as well? Who else needs to be brought to the table? And
Can I just ask what came up?
so one of the groups that came up was early learning. So all of them preschool, so early childhood. Other was LGBTQ community. So do we have good representation in programs to make sure we're reaching that population? We also talked a little bit around integration, and behavioral health partners are here and it's awesome to see. And how do you go from integration in theory into what does it actually look like in practice? And then how will it really affect providers and our clients' lives? So we didn't solve the world though.
No, that's pretty darn impressive. Great, well, great, thank you.
I don't know who the shy one is.
It's Cindy.
So some of what we talked about reflects what the previous tables also talked about. One of the questions that came up for us is all of the proposals that were put forward in the showcase, and how does that integrate to what the aspects are that might be prioritized here, like how do we pick those priorities as this great big group, and then how do we start working on them? When do we have to decide by? And, you know, is there an opportunity, I guess this moves into sort of solving the world's problems, is being able to move into some smaller groups to work on some targeted improvements. And also being able to be proactive and offering up, you know, what we can do to contribute to the overall, you know, goals of this, instead of waiting, you know, for BHT to tell us what to do.
Very good. Thank you very much. Wonderful. Justin, would you mind making note of the two, so what were the two sectors that you felt we should have that aren't here?
So two were early learning, and the other was LGBTQ community. And we don't really have much in the way of organizations representing people with disabilities.
Yeah.
Is another huge gap.
Yeah. Great, thank you, appreciate that. Who's the shy lucky person here? Oh, it's Chris, great.
So some of the things we discussed, we talked a little bit about barriers that would probably stand in the way immediately. One was talked about MOUs and contracts, and when you're getting to that point with different partners, and how to navigate that, because I'm sure each one of us is going to have to find some legal advice through that process, which does not happen overnight, as you guys know, and especially the bigger the organization gets, the longer it takes. Also, policy change. Some of that kind of came through our discussion around shared space. You know, for instance, looking at behavioral health and primary care. How do they share space if they're not under the same organization? And of course, looking at the past talk, and I don't know how many of you guys were there with Ann Monroe from New York when she talked to us about all the hiccups that they ran into. That was a big one from CMS. There was an issue with working at the same time in the same space. CMS said no, and they had to actually go through quite a process to actually get that to be allowed. I mean, there was a great discussion, and I think we started off right off the bat. We did solve the world's problem, but we quickly moved on to the next subject. So, no, we didn't. No, but we started talking about how big this project really is, but you know, one thing I shared is that it's really up to us to make this happen. It's really all of us in this room and the other people that aren't here that I think we want invited. It's up to us to use our entrepreneurial spirit, which some of us maybe need to tap into a little bit, to find out a new way for us to care for the Medicaid population. And I think that's going to be important moving forward. And Ann Monroe made a big point of that it was the entrepreneurial people in New York City, or New York State, that were succeeding. And we can't fit our plans into the same boxes that we've been operating in. So we need to try to create new ones.
Phenomenal work going on at all these tables. So thank you very much. And everybody has their head down at this table. So the shy person is
Danielle.
I would have never picked her. They picked you, not me.
Well, we were talking about a few different things in terms of the conversation about data and analytics and how we're going to be able to use data together with all of the work that we're all doing. And Excelsior is doing some pretty interesting things. with working on a collaborative EHR system through CareLogic, and so we talked a little bit about that and kind of where we're going with trying to make sure that we can get data in real time and really have great information that we can all use to help grow. We have a lot of work to do in terms of integrating not only within the behavioral health realm, but then in the medical realm, and being able to all speak the same language and get on the same page. And what can an EHR do to perhaps help with some of the I don't know, I can't think, the pitfalls we might have. So how can we all get on the same page? So there's some really great collaborative work that we're trying to work on, that more information will be coming out on that. Then Carol was talking a little bit about the workforce issue and the concerns that are I'm sure for everybody in the room. There's the behavioral health providers are fearful that, they're going to be kind of absorbed by some of the larger corporations, if you will. And, what can we do to help, keep our behavioral health brothers and sisters alive in and amongst all this time of IMC and transition and everything like that, and keep everybody solvent. So we talked, hopefully that kind of talked a little bit about that, but I wasn't really planning on talking, so this is all just kind of coming out of my head. Hopefully it's coming out right. Is it? Okay, good. And then also, in terms of outcomes, and when we're looking at outcomes with this new world we're embarking on, when we're looking at the populations that we work with, the chronic, people with chronic mental illness, people with chronic homelessness, the people who, are really struggling to find their recovery from substance use disorders. How do we really help? How do we look at outcomes, I guess, in this new world, knowing the population that we're working with to try to help bring better outcomes? So, and that's something that I think is really important for all of us to be thinking about. And, it feels very overwhelming to think about some of this stuff in this new world. And it's all nice and on paper, and, we can get presentations, but what is it really going to look like when the rubber meets the road? And how do we work together and not kind of go into this in a, competition kind of way, but work is, really to bring the best healthcare we can for people. So, is that good?
Yep. Great job, table. Thank you very much. So, there's no one shy at this table, so I'm not sure how you're. Oh, Jenny? Do you work for Better Health Together?
Exactly. I only got tagged because I was taking notes. So concerns were also people not being represented or not represented here today, specifically the BHO. They would like them here, and then also VA, those dual eligible type of organizations or beneficiaries. Definitely some discussion around wanting more technical assistance with coding and billing issues, some more learnings, maybe one-on-ones, and if not, maybe some smaller cohort learnings, continuing the work that was started with that. And then I guess a note that looking at other systems that are kind of navigating that whole billing system, such as Yakima Valley Farm Workers, CMAR, and a couple of people named there. So another concern is the Provider One system, just a general issue with that. And then also representation from Spokane School District, SPS not being here. And then just general notes of those disparate systems that aren't talking to each other, and as a result, patients such as the VA that are dual eligible are not being treated. So I guess just a lot of discussion around billing, and then also trying to find and fill all the gaps in serving the homeless population.
I had one point that we didn't get to talk about that was trying to move towards, was that as we identify the gaps and the cost savings as we develop the plan and work towards it, and we develop cost savings, is how we go about reinvesting those cost savings for things that aren't going to be cost savings to us, that provide a well-rounded service to individuals, so we don't get lost in the cost savings. Will get our way to fund it going forward, rather than looking strictly at having a better service, but a way to recapture those.
That's a great, great feedback. Good job, table. I am going to say the irony of School District 81 not being here, but they sit on our board. So. Maybe when some of you see him next, at your next meeting, you can say, geez, we missed you, Dave. I don't know.
Email him
So who's and I'm looking at this table and thinking there's no shy folks here, but who was the lucky, is it me? I am not shy.
So I think what was helpful is Torney set up a good conversation starter with respect to the role of prevention. So we had a conversation about really how do we prioritize bringing forward the idea of prevention. Some ideas came forward with respect to, again, just this idea of how do we move away from focusing on treatment and sort of at what space and place we intervene with individuals, and how do we think about ways and solutions that we can address that up front. And so the idea and recognition with early learning and education not being within this space was, I think, relevant to that conversation, though did not come forward in our conversation. I think the other place that we had a conversation about is where there are already a number of existing dependencies within the system, and how do we bring those to light to really leverage and build upon those. So an example that came forward is the role that Frontier plays in medical management. And so how can we think about that and sort of build upon some of those dependencies that exist in the system? So really, you're already showing that there are partnerships that are in existence. And then workforce came forward as well as a core issue. And so I think would just echo some of the lessons that came forward from New York, both within what Anne had shared, but also I think just in general, what we've taken away as CHPW and understanding what was moving forward in New York is that their changes around workforce have come too late. So the idea for really how do you address sort of who can provide what type of care, what are the regulations and barriers that need to be broken down to really address the workforce issue? Because if we start to come forward with what those challenges are in 2 years or even a year, we might be too late, and we might be at that 5-year period and then sort of not feel like we're able to capitalize on the change that we've been able to invest in. So I think that would be a great opportunity to move forward around policy change. And then the final point is around financing. And so just thinking creatively about what opportunities there are and understanding all of the different funding streams that are driving our systems right now, and what opportunities we have to create space with the small investment that's coming through the demonstration, or excuse me, the Medicaid transformation waiver, so that we can sort of have contracts fit the space that we want to see within 5 years.
Great job, table. Thank you. And see, I told you guys that there's nothing but smarties in this room, and I think you're just knocking it out of the park. In regards to Anne Monroe, hopefully some of you got to see her. She was pretty phenomenal from New York, and they had gone through transformation, and so she was here really presenting lessons learned and then opportunities as well. We've recorded that. We have the slides. Okay, and so can we send those out to this group? Great. So those of you who may have missed it, we'll send those and so you can have it. So who's the shy person everyone's looking, oh, Dan, you're not shy, but we'll let you go.
I think a lot of what we discussed, I mean, it overlapped with a fair amount of what's already been said. I think one piece of it was just around one concern area is, as we're looking at the amount of activity that's going on and that kind of needs to go on as it relates to the number of meetings in order to develop the collaboratives and then the projects and then the implementation, there's this feeling of, it almost feels like you need a full-time person from each organization committed just to ACH work. And how do we do that? You know, that piece of it. So there was that, and then another piece was really just around some of what's been mentioned around what type of infrastructure support and help will there be for integrating records with SUD mental health and primary care, and getting us all on the same page with the systems that can and can't be used, and how that effort will be guided and led. Yeah.
Thank you. Very good. Very good job, everybody. My gosh. And what we didn't tell you is we're going to clone all of you. So Dan's concern about too many meetings, it's solved, right? I'm not teasing. No, that's certainly, thank you. We acknowledge that, a lot of work. So we've talked about concerns, maybe some anxieties that all of you had, but I'm hoping that there's some excitement, that there's some opportunity, that there's some good work to be done. So we're almost to the finish line, everybody. We truly are. We're going to ask you to stay with your same group. We're going to let you be comfortable. But this time you have to talk about what are you excited about, and what are what are the opportunities that this could potentially produce. And then we'll round up the day, okay? So discuss.
I'm excited about just the opportunity to collaborate, because the bottom line is, just like Jeff was saying, we have to figure out how to get those gaps filled. A little staff here, a little staff there. A lot of times we get so focused on what we do, we forget about
So much going on.
How does this work already?
It's overwhelming.
We're only a single before we did it.
I know.
Also, I've heard others talk recently about how unsustainable the current system is, especially where it's going for the next 5 to 10 years, and trying to fix it.
Yeah, exactly.
To improve outcomes and better care. We don't do this. Like, it's gonna be really scary.
Yeah.
Costs are going up, and rates are not.
That want this thing. I piggyback on that. Just
Being
I
over.
enjoy the entrepreneurial and I think kind of feeling of it. So.
Oh, okay, so I'm excited that after January, I won't have 15 BHO audits.
Yeah. There we go.
I have 3 next month. I'm really excited. I never have to see those. We might even just give up all the state money to not have to work on it.
Great stuff.
MCO audits are coming out to see, they're just matching stuff.
That was interesting that we're all universally amazed at how many
Screwing up so they can
good organizations.
bam, see? It's just, so that's what I'm excited about. Fewer eyeballs.
That's one of the hardest. I mean, I think everything on there, I know just internally. Yeah, you know, it's. What do you
I
thought?
think it's the same thing, an opportunity to make different collaborations that I wouldn't
They
necessarily
trust that
thought
we're
of.
licensed
Yeah, and that you're doing.
and that we have
Together,
regulations
looking at a bigger
and that
picture,
what
rather
will
than around
play and that's
smaller.
different.
And that you don't keep people in.
So those will be new, and I'll be excited.
We're not,
about
we have to fight for
all never
every
thought.
single one in the SUD system, every single client.
But
That's on the phone.
You know, I.
how do you keep
For
that going?
homeless people to get treated. It's,
Struggle with this is we repeat a lot from meeting to meeting.
it's
Excited to get
not the
going.
qualifications, it's their condescending tone about our people.
Practical.
We really
We're
have
moving
that.
Oh,
So that's
yeah.
exciting. Let's get into it.
It's so,
Suggestions and things there are.
yeah,
But again,
yes.
it's like,
Yeah.
So that would be one area. The other is that.
There's
Yeah.
some bloody acronyms coming out.
BOS.
But I guess I haven't heard that one yet.
Seeing everybody.
They are, they're condescending and demeaning and
Talking about the mobile BHO.
our BHO ASO.
The data.
So we have to run every SUD person, not the mental health. Mental health can do whatever they want, they get all the treatment they need, but SUD people are microscopic.
No.
And if this helps with some of our change
Will be our
staff,
clinical recommendations.
we have to think differently about
Then trying
what we're gonna do as we all.
It's gone.
scary, but it's exciting too.
Yeah, so I'm excited.
And this, it makes me think about all of these big changes. That we actually have a local collaborative to work with. And we have local partners to work with. I know a lot of medical.
We have a lot of great resources. Really raise people.
Before I was writers,
quality of health, well,
and
mentoring programs for children. And
almost
every family we work with,
it really does work.
and we had one staff person dedicated to that with
Oh,
all
and
of
I've
that.
been having conversations with the MPOs saying, yes, this is great. You guys are going to cover life is good.
Anyway,
Because
the job is being
get it earlier, make sure that we're keeping that, getting
whatever.
and that's
So
so far everybody's they think, yeah, we got to do that. How do we do it? Because they also have to do the same issue.
But they don't care about their A1C.
The opportunity to
I would love to have
behavioral health providers
work for free, but most of them are volunteer.
Yeah, it's confusing.
But you rarely get that.
It wasn't that long ago that we finally realized that we were healthcare providers, right? In that sense that it's not a traditional doctor's office, it's reflexive, but it's really.
And sometimes getting into the school district,
The services that,
It's so hard to have a system pass on to us.
That's exciting.
Responsibility.
If everyone, somebody else's quality of life, nothing to that.
So when they're talking about value-based payment or even the medical, the medical side, where they're watching their, the blood sugar and their,
Having a stable thing.
I think that's
how are they doing
right.
it?
Well, that's why I get into it, because by the time we got them done, like conventions, it says 18 mistakes you made prior to that, it has nothing to do with it. It has to do with
And again, intuitively, we know that. We don't, how do we get in there with, like, it's so hard with our mental values about having an apartment, you can't even get them. How does that impact your ability to control your diabetes? Can't get them to show up.
I was one of the kids that drove to school with a gun in
I know
the
it's
car.
that, and we pay them.
When I was in high school.
Right.
You're in Tri Cities, you're out there, that's already, well, you should.
I'm looking forward to
I think
that.
really, like, really good data, because we're all sitting here
I
together.
know. They have no
About
food. Yeah, it's kind of a weird conversation.
Yeah, the program is not.
Well, before, it's usually we're individually looking at.
Right. Right, yeah, I've read a couple of studies, there's a couple of good ones in Oregon, but they're all very, they're building specific, right? There's an apartment building complex.
Okay, folks, if you don't mind spending a minute to wrap up. And then we're going to pick the person with the strongest personality at each table. So whoever that would be. So just take a minute and wrap up, and then we'll do a report out.
No,
I did not.
I don't remember a thing. She had yeah, she remembered well.
After I was reading an email that was pretty.
Pulled it out of her. I don't know.
All the above.
I like that, I just like the snap.
Plug it together.
I was like, where are you from? I'm excited about.
Yeah.
You know, we call our logo where this is my favorite. When I was working so I was in conference. We were talking
This is
about
Green Spokane Valley.
Very cool. And I was trying to explain to her kind of what managed care does, and she was not very Spokane. So I just, changed the conversation. She works in their clinic, and she was working with this homeless individual who, how'd she find a house?
Okay, folks, so I'm interested to hear about what the excitement and what the opportunities might be. So we're going to start where we ended, and who's our presenter or report out at Dan's table? And we're all And you won the lotto, right? You should buy a lotto ticket.
I felt like we actually talked about a lot of different topics under this discussion point. So the first one that we discussed was we're excited about the potential for policy work. We see this as a great opportunity because we have so many different players in the room that if we all get behind one or two or three different topics and all push on it with our elected officials, we think there's a lot of power there. So we're excited. Right. We also talked about partnerships and just the ability to use this platform to work outside of our usual realm, but really to interact with and learn from other players in the community. Very well said. One of the members of the table talked about being excited for the Medicaid enrollee. So we're really excited for the patients and all the opportunities that they will be able to achieve as a result of this work. And we specifically talked about just the ability to break down silos between medical, behavioral health, and dental, and how that's really going to benefit our patients. And then we also talked about innovations, and this is just going to be a great opportunity to test and ultimately to help us move to those value-based payments and to use this work to really prove to the state maybe some different ways of providing services and that those need to be reimbursed.
Wow, good job, table. Good work. So I'll come back here. And so who's the lucky duck?
I think we had a pretty good consensus that lifting the ceiling off and the silos of our own agencies and the community in general, as far as collaborating with each other. And somebody over here said our inner entrepreneurship, and that's the first thing I thought when I looked at the collaborative model was, what can I incorporate into my agency? What would I do better with if I partnered with Jeff to use this service? How would that be more financially sustainable? How would it help our clients break down barriers? But it really just opens the door. I always sound like a broken record, but for new innovative programs, for these new relationships with our funders who are also open to collaboration. We got to hear from Kat, and it was a pretty good speech there. So just the opportunity in general, I think, is what we're all very excited about. I missed anything, guys? Yeah. But yeah, it's going to be a fun one.
Great. Well, thank you. Good job. All right. Did you switch jobs and you just didn't tell us? Or? Allison, I think Jenny just gave notice. I don't. All right.
I think we solved the problems here at this table, though. So hit on a lot of things. As we collaborate more, we're going to be able to ask questions of why systems have barriers and use that information to investigate how to make changes and move those policies. One of Tony's ending before she had to leave was that she is going to use the funding to buy a new EHR system. So collaboration in general will, of people and organizations will putting the needs and wants as well as offering partnerships is exciting. Bringing new and helpful services to those that they serve. And just looking back at the bigger picture of things is exciting. There's some excitement for doing practical work. One comment was that there's a lot of information that has been redundant and now feels like we're going to be getting into some of the practical work. Breaking down silos, building common ground between primary care and behavioral health, because now they have to work together. They're speaking the same language of integration, building up and supporting prevention work, working off of activities that's already being done, knowing that prevention will save money, and then these dollars will, knowing that these dollars will run out, but there's an opportunity to build sustainability.
Wonderful. That was wonderful feedback. So, and the winner, my gosh, it's the same person. I almost want to tell a story about Danielle, but.
Oh, do it.
Do it? Oh!
Let's go there.
So Danielle and I used to work together in past lifetimes, and we went to Tony actually used to host an open house at Native Project. And so Danielle and I were working for the RSN at the time, and so we went to this open house, and Tony got up and she said, well, everybody has to get up and talk about what their agency or organization does so that we all learn, right? It's that shared learning. And Danielle says to me, oh, I don't want to get up there because we had a microphone. And I don't want to do that. So it was our turn, and I said, well, just come on up with me. And so we get up to the front of the room, and I'm kind of in the lead. She's a little bit behind me, and here comes this arm, and I'm in a slight bump, just slight bump. And she grabs the mic, and it was a 30-minute presentation, so I think that is not true. So and here we are reliving it, I think, except for the body bump. I haven't. I
Love you.
Love you.
Teasing.
Love you. That's not a true story. And so it was kind of difficult at first. We were talking about just, it's hard to think about this new world. So there was some shared, sentiments about that around the room. But I think, the idea of working together and, that there's, we won't have, one of the big things was not a whole lot of audits, which I can verify is, for a lot of you, I know you've been through, who loves audits? They're fun. I love doing them. Anyway, but no, there's no, audits are changing, which I know is a huge thing. It's less staff time, away and less corrective action plans. I know that starts making people get a little edgy when I use that word, cap. But so talking about that and yeah, did I miss anything? Huh?
We're excited. We're not excited.
Raising the level of hope is what we're talking.
Here, you go. You get the mic.
Wow, you pick up the.
Well, that really being together and collaborating. I think at the end of the day, I'll start with this, that people in this room care about people, and that's why we're here. And ultimately, I think whether it's Spark or STARS or whomever works with a client, if I refer the client to them because we don't provide, say, the mental health part of the services, at the end of the day, I want to see that client as healthy as they can be. And I would guess people in this room do as well. And so to mutually collaborate and to become more proficient with referrals, I'm excited to know places I can go with clients and getting to know all y'all. I'm married to a Southern gal, so excuse me. But knowing where we can go with our referrals, instead of telling someone no, I tell my staff that I don't want you to just be right angular. In other words, when you come to what seems like an end, put professional polish on it and round the corner. In other words, if you don't know where to refer, then find the place for the individual. Get their name, call them back. Do whatever you have to do to try and be the best service to that individual. And I think that we're called upon that as individuals in life, period, because I think life's about relationships. And so if we can develop those relationships here, we can help our clients in a much more profound way, multidimensionally, multifacetedly, whatever term you want to use for it. So to me, it's very exciting because I just want to see at the end of the day, I want to see more smiles. I want to see more people feeling at peace, because the healthier they are, the healthier mothers they are, the healthier fathers, brothers, whatever they are. And that helps them raise children, or they become happier children, whatever. And so ultimately, if we're collaborating, how could that hurt? As long as we have that desired outcome of seeing them living better lives.
Wonderful, wonderful job. Thank you very much. Okay, so who's the report out? Your table's getting thin, so the people. Okay.
Well, I'll just add a couple things, I guess. One is that we talked about the fact that the system today isn't sustainable. It's not creating the outcomes that we all want for our community. So doing something big is the right thing to do. So that's exciting. And the other thing is that this the collaborations this creates, the entrepreneurship, it kind of breaks the expectations that we set for our own organizations. It was, I think, 5-10 years ago, you're in your own box, you can operate in your organization, do good things, and that's enough. And I think we're kind of agreeing together that that's not enough, and we can do more together.
Great, thank you very much. Lucky person here, okay.
I think we'll just add on to what the last two tables have said, because we really talked about the opportunity of coordinating services better. There's so many services in this room, but are we closing the gaps when people need to move from service to service? So the opportunity would be to close that gap and make sure that we have a tight community and moving people through all the different services. A couple of the other words that we chose to talk about were being a disruptor. And we're going to disrupt, I really like that word, disrupt the system and try something new. So that's kind of a neat thing to do that. And then the other thing is that we're just very excited to get moving and get working. So, yeah.
Great, thank you. Great feedback. Oh, and Sam.
Okay, it is me. So we talked about a lot of the same things that the other tables have talked about, but a couple that haven't been mentioned is we were really excited for having regional data and data, that these projects or these initiatives are going to save the system money, and that we have, especially we talked a little bit about the social determinants of health world, that things like preventing jail recidivism, having housing, having healthy, nutritious food to eat, save the system money in the long run, but we don't necessarily have solid data to back that up. It's something we know intuitively, and there's pilot projects here and there throughout the country, but having a regional impact and data to back that up will be, we're excited for that. We're also really excited to be problem solvers. That's something we're looking forward to as well.
Well, you are so smart. My gosh, good job. Thank you. And you didn't get to talk yet, so it must get to be you.
So I will start by saying it's really exciting listening to everyone go around the room and saying a lot of the same things that our table really talked about, which was the sharing of the knowledge. How do we integrate our services instead of each of us being on our own little silos of this is my expertise and you go over there for that and I won't be a part of it. I'll send you that referral, but that's it. Then I'm off. How do we work together more to be able to help move our clients forward to really being able to have quality of life?
All right, my gosh, all of you should be feeling pretty good about yourselves. You did a lot of great discussion, so thank you very much. I think that was really helpful for all of us to hear, and really helps for us when we move forward with the collaborative. So great job. Again, really reinforcing all this subject matter experts and the smart people in the room. So again, I hope you're feeling good about your new coworkers, because they seem like a pretty darn good bunch to me. Just guessing. So we are going to finish up today. This was our first meeting in regards to this foundation that we're really trying to support in regards to building this collaborative and really having you take ownership and be the governing yourselves and running your own collaborative. So this was the first step. April 10th, we'll have a second meeting where we're going to focus on some ideas and structure. And how are we going to develop some processes to get the work done, which was echoed a little bit in some of your concerns and feedback that you gave. So we're really going to take a deep dive on that. And then, oh, I'm sorry. So April 10th, it'll be 1 to 5. We will have lunch again at noon. And then on April 26th, we'll go from 1 to 5 again, and we'll have lunch at noon. You don't have to come at noon for lunch, but I think some people enjoy networking and talking, and I certainly appreciate that too. And Chris is 1 to 5. Yeah, yeah. It is April 10th is where, Justin? And so April 26th will be here at Better Health Together. April 10th, we ran into a snag in regards to where. I'm pushing for Honduras, if any of you know where Honduras is at, but we will send you confirmation It's free parking, right? Nice place. So, but we'll send you confirmation in regards to where that's going to be. No, no March 27th, because that's the priority Spokane, and they're doing their needs assessment. I'm butchering all of that. But on March 27th, we didn't want to conflict because we got feedback from a lot of partners that was a really important meeting. And what's the meeting called, Tony?
It's the final report of the community collaborative doing the assessment, looking at various sectors. Roughly 200 people are planning to attend, and all of you are welcome. I believe it is, I'm going to say 4. It's next to the bookie. And Chris, do you know, is it 4 o'clock?
2 to 4.
2 to 4.
And it's at 410 East Spokane Falls Boulevard.
Yeah, so it's right next to the bookie.
All right, so if you have questions, ask Tony is what I have picked up on. Yeah, no, thank you. No, we did try to send out the email about the 27th. Really appreciate that, though. Thank you for bringing that up. So April 10th, April 26th, we'll let you know in regards to the location on the 10th, most likely in Durris, but we'll confirm that. And then April 26th will be here at Better Health Together. Again, we'll have lunch at noon, optional, up to you. But I think that was time well spent by more than a few of you today. And just one last thing, if we don't have your email, say you got this forwarded from your boss or coworker, we do have a sign-up sheet on the table outside the door, so we can just make sure to get your emails. So thank you, tremendous work today. Thank you very much for agreeing to be a part of this, and I'm excited. I'm excited for April 10th and the 26th and just the work going forward. So thank you very much. Take care.
Yes. Yes, because these 6 groups have been meeting for like 3 or 4 months. And each group has looked at.
No, I can't.